Good afternoon. Thank you for joining us today. My name is Jess Laporte, and I am the Education Committee Chair for Illinois Society for Cardiopulmonary Health and Rehabilitation, otherwise better known as ISCHR. First, I would like to thank my committee members, Leanne Raiders and Jamal Ozemick, for their help in putting this together as our second non-traditional education session, where we focus more on the networking and seeing what other clinics are actually doing for cardiac rehab. The format for this panel will be as follows. Majority of our questions are pre-assigned questions asked by our moderator to two of our panelists. If another panelist wants to add something that's different after two panelists have answered the question, they may. However, keep in mind we do not want to be too long on one question, and we want to try and keep the session under 60 minutes. A few questions are volunteer questions that the Education Committee felt needed more feedback, and any of the panelists can step in and answer. And now I would like to introduce our panelists and our moderator for this evening. Our first panelist is Jim Baumgartner, who is a master's at the University of Illinois Chicago in exercise physiology, earned his bachelor's at the University of Buffalo with exercise science and a concentration in sports medicine, is ACSM clinical exercise physiologist, is involved in the field of cardiopulmonary rehabilitation for the last 22 years, currently is the manager of cardiopulmonary rehabilitation at Franciscan Health Olympia Fields, was previous manager of cardiopulmonary rehab at the University of Chicago Medical Center and Elmhurst Hospital. His special interest is exercise for management of CHF and is coordinated exercise arm for the heart failure action trial at the University of Chicago. Our next panelist is Mary Wagner, Bachelor of Science in Nursing, Masters of Education with specialty in exercise physiology, a certified cardiac rehabilitation professional, has over 36 years as a nurse and 20 plus years in various cardiopulmonary rehab programs. Previously has been past president of ISCHR, past secretary of ISCHR, and previous education committee chair for ISCHR, and currently is our Northern Illinois Regional Committee chair for ISCHR. Our third panelist is Eric Ostrowski, who is a master's prepared exercise physiologist who has been working in the cardiac and pulmonary rehabilitation field since early 2013. He is an ACSM registered clinical exercise physiologist and holds a certified cardiac rehab professional credential through AAZBPR. He started his career in Southern Illinois, go Salukis, but has recently relocated to Tulsa, Oklahoma, area where he successfully opened up and manages a cardiac rehab program. Eric is also the president-elect for ISCHR. Next, we have Barb Masters, who is just recently our president for ISCHR, so now is our past president of ISCHR. She is appointed a fellow of AAZBPR back in 2016. She has been in cardiac rehab for over 25 years, pulmonary rehab for 3 years, when she became the coordinator of both as assistant nurse manager for cardiopulmonary rehabilitation. She works at Memorial Hospital in Belleville, has a master's in nursing, and board certified in cardiovascular nurse for 14 years. Also has a CCRP credential for at least 2 years, and also co-authored several journal articles. One of my favorite is the diabetic one in the JCRP for recommendations or cardiopulmonary rehabilitation statements for treating diabetes with cardiopulmonary rehabilitation. Next, we have Cindy Hooper, who is a bachelor's in physical education, fitness leadership from NIU in 1987. She earned her master's of education, physical education, exercise physiology from NIU in 1991. Was an NIU, Northern Illinois University instructor in 2006 to 2008. And one of her favorite classes was teaching cardiopulmonary disease and rehabilitation. Currently, she is a clinical exercise physiologist in cardiac rehab for Northwestern Medicine, and she is ACSM certified in registered clinical exercise physiologist, and actually is still certified in an old certification, which I didn't even know existed, exercise test technologist. And she now currently is our ISCHR secretary and takes wonderful notes for us. Passions other than cardiac rehab are traveling to new places with husband and 2 teenagers, playing volleyball, motorcycling, and usually working out and running and lifting. Next we have is Betsy Hart, who is a master's in clinical exercise physiology and from Benedictine University, which is my alma mater. Bachelor's in nutrition from Benedictine University. Is an ACSM clinical exercise physiologist, AACVPR certified cardiac rehab professional. Involved in the field of cardiopulmonary rehabilitation for over the last 12 years. Is currently the manager of cardiac rehabilitation at McNeil Hospital in Berwyn, Illinois, and was previously exercise physiology manager of Wish Center and Bariatric Weight Loss Center. And was my mentor in cardiac rehab when I first started, so I'm very happy, Betsy, to be on here with us. Barb is one of my bigger mentors too, so with all my colleagues and mentors, it's nice to have all you guys on here. And the last 2 are 2 of my committee members who this will not be done without these 2 being present. So I thank you both. Leanne Raiders, who is a cardiopulmonary nurse at FHN, and again is an education committee member for the ISCHR, and recently just received her bachelor's or her board certification in cardiovascular section. And how many years, Leanne? Have you been in cardiopulmonary rehab?
Approximately 4, 3 full-time, and then I did another part-time.
Okay, great. Okay. And lastly, who will be our moderator today is Dr. Jamal Ozimek, who is a clinical assistant professor and the director of the University of Illinois at Chicago Cardiac Rehabilitation Program. University of Illinois at Chicago Cardiac Pulmonary Rehabilitation Program. He receives his Bachelor's of Science in Exercise Biology from the University of California, Davis. His Master's he earned in Health and Exercise Science from Wake Forest University, and then his PhD from the Human Performance Lab at Ball State University in Clinical Exercise Physiology. And then completed his postdoctoral research fellowship at the University of Colorado Anschutz Medical Campus. He has over 7 years of cardiac rehab experience, and just another note, spoke at our last annual ISCHR conference, does many different things of research. He has some great articles. If you look at, there's one in ACSM Health and Fitness Journal, back when he was a grad student, great one on heart failure, and also does a lot with research for heart failure patients, as well as women and cardiovascular disease. Did I cover that right, Jamal? Anything you'd like to add?
No, that was perfect, Jeff.
All right.
That was perfect. Thank you.
All right. So what I will do is I will bring this back over to Jamal, and he will moderate this panel discussion.
Excellent. Thank you so much for that great introduction, Jeff. So we'll just go ahead and get started. The first question from one of our ISCHR members is for Leanne and Mary. Does anyone have standing orders for phase 2 to facilitate getting patients in sooner and not having to rely on offices to send correct orders?
If I may go ahead and go, this is Leanne. We currently have standing orders for anyone that comes out of our cath lab area with stent placement or angioplasty. We don't do any open heart here, so I don't deal with those for standing orders, but it has worked very well with the standing orders from our cath lab. We're currently able to get them in approximately 14 days, give or take a little bit, and it's working quite well. The outside facilities fax us their referrals. Because we are a rural hospital, a lot of our surgeries, open heart surgeries, are done in either Madison, Wisconsin or Rockford, and people that live in the area like to come to us, so they will refer them over for a shorter distance because it's 3 times a week. So far that has been going really well, and we average probably about 25, 28 patients normally per day. Thank you.
And this is, hi, Leanne. Thanks, Leanne. This is Mary. And it's interesting that I was assigned this question because we went through quite a process on this exact question back and forth because we wanted, as cardiac rehab professionals, to have standing orders, and our doctors were very concerned about that because we're a referral center. So I work at Loyola University Medical Center. We get people from all over the state of Illinois and Wisconsin and Indiana. And so their concern was if we gave them standing orders and then they went back to Indiana and started cardiac rehab and they went into VTAC, our doctors were no longer following their care and no one was involved that was following their care. So what we came up with was a system where when they either have bypass surgery or a stent placed or an MI, they go into our registry, for lack of a better term, but our list of patients, and each of them is sent a letter. And it says, these are your options for cardiac rehab. This is what we recommend. All of the patients that would be coming to our facility based on location, we follow up with their doctor to get an order. But patients that are outside of the system in Indiana or Southern Illinois, we simply give them a letter that states what the near hospitals to them would be and that they need to get an order from their local physician so that that person is involved before they start in cardiac rehab.
Excellent. And then Mary, with that system, have you noticed an increase in patients being referred to cardiac rehab? Or would you like to see it kind of go one step further?
We've seen a huge increase in the patients referred, so much so that we couldn't handle the volume. It was a problem as far as us having too much volume. And so we had to, request extra staff to handle that. So yes, we think it's a great system as is. I would prefer to have standing orders, but, we have to do what our physicians are comfortable doing. And I understand that if they get a referral from Southern Illinois, they don't want to get a call from the program saying, well, you sent us this order and this patient's having this problem. They really need to get their local physician involved. So I understand the argument.
Mm-hmm.
Sure. Great. Thank you, Leanne and Mary. So this next question is going to be open to the entire panel. So in your Phase 2 cardiac rehab program, what criteria for patients are you using for unmonitored exercise? So unmonitored EKG exercise.
This is Eric, and I can just speak to what our program uses. We utilize the AACVPR risk stratification criteria, and our policy is set up as such that if a patient is stratified into the high risk category, they'll receive a minimum of 12 EKG monitored sessions. If they're moderate or high risk, they'll receive a minimum of 12 EKG monitored sessions. If they're stratified in the low risk category, they receive a minimum of 6 monitored sessions. All of that comes with the stipulation that at any time that a patient moves to the unmonitored program, if you will, that if they have any drastic changes in their cardiac medications, if they have any rehospitalizations or any other issues, that we have the ability to spot check them with the telemetry system as well. So that's how our program does it.
This is Barb. For our unmonitored, I have to say we're still on the old way of doing things, of using the non-monitored basically for education purposes. Basically because we have found insurances that are requiring that they only stay on the monitored and they will not pay for the unmonitored, the 97 CPT code. So instead of worrying about which patient can do what monitored, unmonitored session, we basically keep them on all the time until they finish up the program.
Does anyone else go with the non-monitored program?
This is Mary. What we do is to wean them off the monitor in their last 12 sessions for the purpose of transitioning to them to self-monitored exercise and having them more comfortable. So we initially have them, go to 2 days a week and then 1 day a week and then no days a week. And we also wean them off of any blood pressure monitoring because eventually they're going to have to exercise without that being in place, and we want them to be comfortable.
Yeah, this is Jamal. I completely agree with those points, because this has been a topic that has been hotly debated within the cardiac rehab world, and I personally believe that I think we need to move more towards a system where we are, weaning the patients off of the monitors to not only increase their confidence in being able to exercise on their own without being monitored, but to also be able to have them exercise within the program in a setting where they feel comfortable exercising without the monitor. Great, thank you for the panel for your feedback on that question. So the next question is going to be for Leanne and Eric. How are you recruiting heart failure patients to rehab if you don't have a heart failure clinic within your hospital?
This is Leanne. We do not have a heart failure clinic here. What we do have is a home monitoring system. They occasionally will refer us some in, but what we do have in place, and we're a 100-bed hospital, and when patients come in admitted, they are flagged at admission if they are heart failure. We have a report that prints off daily of all patients that are flagged in heart failure, and we look at their reports or their history and physical, et cetera, to see where they're at, if they're in any systems. And if they meet the heart failure program criteria, we will contact their personal physician, primary physician, and get an order.
This is Eric. I think what Leanne said was terrific. We do somewhat of a modification on that, but we still, it's a lot of navigating on our part, and with us having a smaller program, a rural program, and not quite as much staff. We have the system we have set up now, which I don't believe is completely optimal, but once again, we don't have a heart failure clinic or anyone designated with their jobs to navigate these patients for us single-handedly. So what we do is weekly we run a report for patients that have been discharged from the hospital. They were discharged with a primary diagnosis of CHF, and we also run an echo report from the previous week that tells us all the echo, gives a rundown of all the echocardiograms that were performed in the hospital and what the corresponding EFs were for those patients. And we combine those two reports. We go through those patients' medical histories if they're appropriate for cardiac rehab. Then we will reach out to usually either their cardiologist or their primary care physician or whoever's reading the echo and try and navigate them and get them into the program that way. But it creates kind of a delay. But we do have that 6-week window there, assuming you don't have an echocardiogram or some evidence 6 weeks prior to get the patient in. So that's what we do.
Yeah, I think with heart failure patients, the general thought, I think global for most physicians, is that if a patient has heart failure, then they're extremely deconditioned and it's unlikely that they're going to exercise. So what's the point of referring them to cardiac rehab? And of course, we all appreciate that that is completely false. Have you run across any struggles with your cardiologists in trying to convince them that exercise is an appropriate therapy for heart failure patients?
This is Eric. I personally have not. Our cardiologists seem to be on board and receptive that cardiac rehab is without a doubt beneficial for heart failure patients. It's just a matter of getting them to understand that not all heart failure patients qualify for cardiac rehab, which is extremely frustrating because I'm sure they see in their practices every single day the patient with slightly reduced EF or severe diastolic dysfunction, and they don't, they want to send them over for rehab, and they're very deconditioned, but then we have to tell them they don't qualify. So it can be a little frustrating from their standpoint, I believe.
And Leanne, how about for you?
Our cardiologists are on board with sending heart patients in. In fact, like you said, they try and get patients in that really don't qualify. Our home monitoring system that we set up probably about a year and a half ago has actually helped a lot of our heart failure readmissions. and you're familiar with those. They monitor at home, check weight, blood pressures daily. And our problem actually is our primary care physicians. We did an education where we went out, handed out pamphlets, kind of gave them a little information on our home monitoring system and on our rehab facility and what we could do, and the response wasn't what we had hoped for.
Right. I think with all the wealth of evidence that we have supporting exercise in cardiac rehab and heart failure patients, I'm noticing a general trend that most cardiologists and physicians are getting on board, whereas 10 years ago it was not the story. So the next question is going to be for Barb and Cindy. What do you use for staffing guidelines, and what is your professional mix? So monitor tech, nurses, EPs, respiratory therapists, PTs, OTs, for phase 2 cardiac rehab.
Hi, this is Cindy. Our staff consists of 5 nurses and 2 exercise physiologists. We're also lucky enough to have a full-time secretary, which she's really the glue that keeps us together. We also have 1 nurse who's PRN, 1 EP PRN, and we also have a respiratory therapist who's PRN as well. We're all pretty much interchangeable in the phase 2 area. Probably the only people who don't sit at the monitor would be the respiratory therapist. She helps out more on the floor. But we have 6 classes total for phase 2. We have 3 classes in the morning and 3 classes in the afternoon. Our telemetry system can take up to 8 patients at a time. Currently, we're not doing anyone unmonitored, although we would like to move in that direction. So we all take turns. Sometimes we're at the monitor. It could be both. Myself, I'm an exercise physiologist, so it could be me and the other exercise physiologist running the class, or it could be 2 nurses, or it could be 1 nurse and 1 EP. Usually, if there's only 2 or 3 patients in the class, maybe we had some unexpected cancellations, we do have a laptop monitor that oftentimes, if it's that small of a class, one of us would just do the class by ourselves, because we can just be mobile and move around and be out on the floor, keeping an eye on the monitor and doing the documentation, and at the same time getting blood pressures and interacting with the patients. But for the most part, 2 people are assigned to each phase 2 class.
This is Barb. We have a similar mixture. We have 3 RNs, 1's full-time and 2 part-time, and that's including me as a full-timer. I have 2 EPs, and they're both full-time. I have 3 RTs, and they're part-time. So I run cardiac Monday, Wednesday, Friday, pulmonary Tuesday, Thursday, and we start at 8:30 in the morning to 6 o'clock in the evening, and running anywhere between 6 to 7 sessions, 12 monitors. So my mixture can be RN, EP, RT, or 2 RTs, 1 RN, and 1 EP throughout my whole combination through the week. As the need arises, I have 12 monitors for cardiac, and I can have up to 8 to 10 patients in pulmonary.
That's fantastic. It's really great to hear that your facilities are utilizing a multidisciplinary approach to improve and enhance patient care. So when you're developing your program and when you're looking for potential staff members, what are some thoughts that you use to decide how many EPs you need, how many nurses, how many respiratory therapists? Is there a formula that you use and think of?
This is Cindy. I don't know that we use a formula per se. I think that the last time or 2 that we've had a job posted, I want to say it's been posted as either RN or EP. I think what's most important is that we get the right person for the job. There's got to be definitely the right person to work in cardiac rehab. It's not so much whether it's a nurse or an EP. It's got to be that right person.
I agree with Cindy. If you don't have the right mixture, being whether or not they consider themselves just an EP or just an RT, it's not going to work. They are all talented people, and they bring so much to the mixture of a program that we can call upon each one for their best qualities, and it really makes the patient appreciate that.
That's excellent. I absolutely agree. The next question will be for Barb and Mary. How many different modalities do you use in a phase 2 cardiac rehab session?
Barb, you want me to go?
Please do so.
First of all, I have to say I am like majorly jealous of your guys' staff because you have ample staff compared to what we have, and dang, I wish I had that. Anyhow, how many different modalities? It totally depends on the person. So when we see them for their intake visit, we try out different pieces of equipment. We have people that only can use a new step and an arm ergometer. We have people that can only use a treadmill because of orthopedic issues or stroke, safety issues, etc. We have people who tell us that when I graduate, I'm going to only jog, and so I only want to go on the treadmill, and we allow them to do that. So we really try to individualize it. We do have people who prefer shorter intervals, and we have people who prefer longer intervals. We have 4 treadmills, an elliptical trainer, 3 options for recumbent type bike, either recumbent bike or a bike ergometer. We have 2 arm ergometers, a couple of new steps, and a couple of airdynes. So I can tell you which piece of equipment gets used the least, and that's an airdyne. People hate those things. And then weights, and that's again dependent on their goals and interests and what their body can handle. So I would have to say it's very, very individualized, anywhere from 1 to 7 modalities.
At our facilities, this is Barb, we have a complete up and running type of gym area so they can do the treadmills, new step, recumbent ellipticals, roll machines, free weights machines, new steps, arm ergometers, and windjammers. So it's basically based upon their progression, what they feel like they want to do, what they're going to do after they leave me, and as well as if I can give them a little bit different aspects on cross-training as to whether or not they're going to strictly do a bike, can I persuade them to do some weight resistance and keep up with the 150 minutes of exercise most days of the week, and the 2 weight resistance episodes 2 times a week. So it's very independent, but we do limit it to 45-minute periods of time.
Great. Excellent, Barb. Thank you, Mary. Next, this is open to the entire panel. Do you progress your low-risk and high-risk patients differently? And if so, how?
Well, I'll
Eric,
jump
would you
in
like to
since
go?
nobody's talking. So this is Mary, and yes, we do progress them differently, and usually it's almost self-selected because a lot of our high-risk patients are unable to progress more aggressively, and also because of orthopedic issues, sometimes they can't progress as aggressively. But I will say that we have some patients who have severe heart failure and do really well with higher level exercise. So we don't hold them back based on their risk, but we base it on how they tolerate the exercise and progress people who are having more difficulty with exercise or who are more symptomatic more gradually than we do younger, non-symptomatic, lower risk patients.
Eric, would you like to go next?
Sure. I think I agree completely with Mary. I mean, we progress patients the exact same way, whether they're, regarding whether they're low risk or high risk. But I certainly, what I appreciate the most from Mary's response is that she's not going to hold the patient back just because they're high risk and their EF is low, for example. If they are able to tolerate higher levels of physical activity, that we accommodate that, and we let them do so. So, but yeah, we progress them pretty much the same. I mean, our monitoring policy is a little bit different. Like I said, our moderate and high risk patients are on for 12 sessions at least, and then our low risk are on for 6 at least. But if the patient's tolerating the exercise, we continue to progress. So.
Great. All right. So I think most people would probably do similar practices, low versus high risk, certainly increasing and progressing them, hopefully at the same rate, but certainly at different intensities and different volumes of intensity for each one. So the next question will be for Betsy and Eric. Are you doing any pre and post cardiac rehab stress testing, and how are you reimbursed for each one of those? If you are not able to do pre and post rehab stress tests, how are you utilizing the 6-minute walk test and MET levels from third and last sessions?
This is Betsy. I'll go first. We do a pre and post stress test on every patient, or should I say we request one on every patient. We don't perform the stress test in our department, but we are linked with a cardiology group across the street who, the best way to describe it to me is sort of a win-win for both of us in our relationship. If they order cardiac rehab, they know they're also going to get to order 2 stress tests, one pre and one post. So we've pretty much, for a nice way of saying it, we pretty much trained them to say, okay, well, anytime we order cardiac rehab, we're going to order a pre and post stress test. And it's actually in their EMR, it's automatically, all 3 are checked together. So when they check cardiac rehab, it automatically checks a pre and a post stress test, and all 3 print out together. So we don't have anything to do with the reimbursement because, again, we're not performing the test, but I know that their cardiology group is just like any other cardiology group, is in it to, make a profit. So I know if they weren't getting reimbursement, they would stop ordering it.
Excuse me. Are you using standard or nuclear stress test?
We order a modified Bruce on the pre and a regular Bruce on the post. It's up to the cardiologist if they want to order a nuclear. If there was anything on, let's say, their cath that was questionable or they were still symptomatic, that would be up to the cardiologist. But the standard for us is a modified Bruce on the pre and a regular Bruce on the post. And we can definitely, if we know the patient, let's say they've been through rehab before or we're familiar with their case, there's definitely been times where even on the post we've recommended the modified just because maybe they're high risk and very, very low conditioning. But most patients can handle the modified Bruce pre and regular Bruce post. I would say across the board, that's pretty standard for us.
Okay, thank you.
Betsy, this is Cindy. I have another question for you.
Yeah.
Would you say that the tests that they're doing pre and post, would you say it's more of a functional test, like the endpoints would be volitional, or do they stop them at a heart rate?
That's a great question. We also, I would use the word trained. We have trained them to let it be a functional test to exhaustion. That's taken a long time for us to get across. They used to do it either to a set heart rate or tell them not to take their beta blocker, but we have conditioned their, like for example, their front desk will read them the instructions and it will say, if this is your pre-rehab stress test, take all your medications in the morning as usual. When you do your stress test, we want to see what your heart rate, for example, would be with the beta blocker in your system. Obviously, they don't read that whole thing, but that's what we've kind of trained them to say. So the patient will go for their stress test with their meds in their system, and we tell the techs that perform the test, unless you're seeing something on the monitor, take the patient to the point where the patient asks to stop. And we always tell the patient, we really want to see what you can do, even if you only can do 2 minutes. Or if you can do 12 minutes, but we want to see what your limit is right now so we know how hard to work you. And then the second time around, we tell them, this is what you did on your first one, and we kind of coach them, this is how many minutes you have to do on a regular Bruce in order to achieve a higher MET level than blank, which is what you did on your first one. So most of them go in, and they're really geared up to say, hey, I got to get past, 5 METs, that's what I did the first time, and the technologist is like, wow, your cardiac rehab patients know so much about METs. and really informed. So the patients are really involved in the process too. They understand the kind of the method to why we make them do a pre and a post. And the cardiologists are totally on board. I mean, even in their letters, as far as progression letters and H&Ps, they'll mention, patient improved their MET level by this many points or this percentage. And they're pretty bought into the process as well. They kind of understand what we're trying to show as far as progression. So I think that helps with them remembering to order it.
Wow, thank you. I just think that's awesome. That's great.
Yeah.
Yeah, now I've been there for 12 years. I would tell you the first year I was there, it was not like that. It's taken me a really long time. It's sort of like your spouse. You have to kind of work with them to get them to, do the things that are symbiotic in your relationship. And I feel like that's sort of how our relationship with our cardiologist is, it's taken a long time. And every time they get, for example, a new stress test tech, we have to start over with kind of saying, no, we don't want you to stop at 9 minutes, or because the heart rate isn't certain. We want you to go until the patient says stop, and don't make it, a certain number. Make it when the patient is tired. And then the reason for termination should always be either like leg pain, shortness of breath, or of course, unfortunately, if they see something on the EKG, but not just, we used to see like protocol achieved or something like that, and they would just make them do 9 minutes. And we were like, why 9 minutes for a modified Bruce? And I don't know who made that up, but it took us a long time to change that, and also that it's not a certain heart rate because they are going to take their beta blocker, so they're not necessarily going to get to that target heart rate on the standard stress test. And they also understand that's not why they're taking the test. They're not taking it necessarily for diagnostic purposes, but for functional purposes. And so the cardiologists understand if they're looking at a pre-rehab stress test or a post, they'll even go back in their dictation. They'll look at the pre, they'll look at the post, and they'll dictate the change in their post-rehab assessment.
Nice.
Yeah, but like I said, a work in progress.
So this is Eric, and my answer is not nearly as fun. We don't use stress testing. I wish, and I think a lot of us on the phone are thinking like, man, that'd be really cool to get train our cardiologists to be able to order those stress tests like that, especially get them on board with letting the patients stop at a voluntary fatigue endpoint or and not take the beta block, do a stress test while they're on their beta blocker. And so very envious of that. But we don't use stress testing. That'd be wonderful if we did. So what we're using for our functional assessment performance measure is we're tracking peak METs, and then we just use the peak METs that the patient achieves on the third session and compare that to the last session. So that they're in cardiac rehab. So I've kind of steered away from the 6-minute walk test myself just because of the ceiling effect associated with it. But I've spoken a little bit to Jeff Laporte here recently about maybe starting to use that again. So and then there's other things we can look at too, like the talk tests and other submaximal exercise tests that can be valuable from an exercise prescription and a performance measure standpoint. But right now we just use my program just uses the peak METs. So
great. And Eric, so I think we all can agree that exercise testing would be kind of the gold standard. What are some of the limitations in your facility that prevent you from being able to perform those tests?
Great question.
Cardiologists? Is it time? Is it staffing?
It's probably all the above. We didn't come into this starting this program up about a year ago. We didn't come into this trying to set the program up in such a way that we would have pre and post stress tests. So I don't have a lot of experience getting that set up. Perhaps I need to get with Betsy and find out how she got it. But I like how she, at her program, they've kind of sold it to the cardiologist, if you will. You get a couple stress tests, and I mean, at the end of the day, I mean, you hate to say it's for the money. I mean, there is definitely we know the clinical value in it. So there is value, a lot of value there. So maybe it's about letting them know that the value's there and educating them on that process. So I would say that that's probably a barrier, maybe, or that we just have to spend the time to reach out to our cardiologist. And in all honesty, we haven't requested it, to do that. So I guess the fear is that they'll just say no and that it's a waste of time. So, but the way Betsy described how they went about it. It took some time. It takes building trust with your cardiologist and explaining the value and the purpose of them, and how both parties can benefit, us as well as your office or your practice. So going about it from that standpoint could very well be the way to do it.
Yeah, and one more thing, this is Betsy again. I also would say a lot of when I say working with the cardiologist is also just working with either their practice manager or their nurse, who we all know does most of the work, and kind of getting them to, once I get the cardiologist to understand, yes, I totally understand why you want to do a stress test. That's no problem, but is he going to take the time to necessarily order it? No, so that's where we kind of went around the back door and said, okay, how can we make this simple where if he's willing to order a cardiac rehab and remembers to do that, bing, the other two will fall in line, and he doesn't, because I don't want to have to remind him again, oh, and you need a pre, and you need a post. We just do it all at once. They can always waive it. There's rare times where they'll waive it, but usually it's automatic because if they're ordering rehab, the pre and the post will automatically kind of trail with that. We do struggle a little bit more when we get referrals from other hospitals. We do get a lot of patients from other hospitals, and that does require a fax, a phone call, and sometimes an explanation. But again, once we have an established relationship with that office and they know they're going to be sending patients to us, they also know, oh, we're probably going to ask for a stress test. And I would definitely say they waive it more than our cardiologists do, but I still feel like we do have success in requesting that order. And we'll send an automatic order that all they have to do is sign it. And it's a pre and a post, and then they can either have it at McNeil or at their own hospital, whatever the doctor prefers.
Betsy, this is Eric again. Random question to piggyback off that. Post-program lipids. Do you guys, have you thought about attaching post-program lipid panel to that to find?
Yeah, we do. When we do their case management, so the initial, the 12, 24, and the final, we want to have at least one lipid during that 3-month period. We don't do a pre and a post lipid, but we want to make sure they have at least one upon enrollment. And if we don't have one, that's one of our goals, is to chase down that cardiologist or primary care and make sure we get at least one order for a lipid panel and have it done during their course of 36 sessions. So, and that's another standard fax. We basically turned it into an order and check the box here, sign it, and it becomes an order that they can take to the lab. So all the doctor really has to do is sign the fax and have his, staff fax it back.
Great, thank you.
Great. And then Betsy, this is Jamal. One more question related to exercise testing in your program. Have you found that you've had issues getting the second or the post-cardiac rehab, the post-exercise test covered by insurance?
No, I mean, I know that's probably partly because it's not being done in our office. But like I said, I know the group that we primarily work with would not perform a test that they were not getting reimbursed for. So there's been no red flags on their end that have come back to us and said, hey, you're having us order this second test. It's not covered. We're not going to do it anymore. I mean, like I said, I've been doing this for 12 years. I haven't had an issue with it. A few times at the hospital, the patients have had it at the hospital. The patient will say, I did it the first time and my copay was this. I don't want to do it the second time because I know what my copay is. And then we'll just let the doctor know that, it's a financial issue as to why the patient's not doing the second one. But when he's in the cardiologist's office, that has not been an issue for us.
Gotcha. Excellent. Thank you so much. Yeah, and Jeff, I think we found our new topic for the next education service.
Yeah.
how to convince cardiologists to implement exercise testing. So everyone stay tuned for that.
Yeah.
All right, so for the next question, this goes out to the group. How many patients whose insurance does not cover phase 2 rehab decide to start phase 3?
This is Leanne, and I'll step in. We have patients whose insurance does not cover the phase 2. They mostly, if they know they have to cover phase 2, they don't even attend phase 2, let alone phase 3. So if insurance doesn't cover it, and even there's a insurance company out there, Coventry, who seems to have large co-pays of anywhere between $25 to $50, which at the end of the week adds up, and so therefore at the end of 36 sessions, it adds up. Most of our patients we do take to 36 sessions. However, if they do have this, or if they are extremely active and are doing well, we will graduate them early.
This is Mary. We don't have phase 3, so it isn't even an option at our facility, but we have had multiple patients who don't have coverage for phase 2 because they don't have a diagnosis to support that coverage. So if their doctor orders it, what we offer them is to do 2 or 3 sessions of phase 2, and we can provide them with feedback and some general exercise guidelines from that. And we've had a lot of people take us up on that and just pay for, self-pay.
This is Barb. We have what we call Target Your Health program for the people that cannot pay the high copays per session, as well as not covered underneath their insurance policy. It's $68 a month. It's very reasonable for people that have that copay of $30 per session, but it allows us to say to the patient that we can monitor you maybe once, doing a 6-minute walk test, do an EKG, do an evaluation on you, progress you for 12 sessions, and then you get to decide on if you want to go to a phase 3, which is less expensive, but we wouldn't be doing any monitoring on you except supervision.
Yeah, this is Jamal. So we're currently in the process of developing a phase 3 program. Our phase 2 program is just under 2 years being active right now, so that's certainly going to be our next step. What we've tried to do, because we have a number of these cases where patients are either not qualifying for phase 2 because of insurance purposes, or they just don't have the diagnosis to be able to do phase 2. But they have a cardiac condition. And so what we've tried to do is create kind of a network of other phase 3 programs within the Chicagoland area, such that we can find which program is closest to that patient and where they live, and then start referring that patient or those patients to these programs so we can get them active and starting them on kind of the healthy lifestyle that they need to start to be able to improve their health state. Great. Okay, thank you for your responses on that question. We have 2 more questions to go. The next question is for Cindy and Jim. How are different sites registering their patients into phase 2? Are they using a hospital-based registration admitting system or registering patients themselves? How long does it take to get the patients from discharge to rehab? Cindy, would you like to go?
Yeah. To me, this is a complicated answer, maybe, because I think there's a lot involved with this question. We recently went on to received a new EMR about a year ago, and that really changed so much of our processes, especially in regards to how patients are scheduled, how they're registered, pre-certs, who does what job task. And initially, it was going to be that only our secretary would be registering the patients. But as time has gone by, a couple of the staff members have been trained how to navigate in the EMR and how to do this successfully. Because in the EMR, there's a lot of steps that have to do with the communication with the billing department and how the charges are generated, so that everything's accurate and goes smoothly. It can take several minutes just to check in a patient once they arrive for their session. And so first, actually, they have to kind of be arrived, and then we have to charge them. So there's quite a few clicks that we have to do to make sure that each patient at each visit is successfully registered for that visit. 80% of our orders come through the EMR, and the way that this is set up, the order has to be attached to all the visits, and all the visits have to be linked together. I don't know if this is making any sense to anyone, but it's when you go to register them for their first session, basically our secretary just meets with them for 5 minutes, and that she does all the things that she needs to do on the computer to make sure that the appointment's set up correctly, the registration is correct, the billing is correct, and she kind of takes care of all that so that the rest of the sessions, as they are going through the course of cardiac rehab, that everybody is arrived and checked in without too much time put into it. 20% of our orders come by fax, and those have to be scanned into the EMR, and then those have to be attached to all the patient's sessions. It probably takes anywhere from 10 to 30 days on average for a patient to be starting cardiac rehab from the time that they're discharged from the hospital. Sometimes it's longer because some of our doctors do want the patients to have a stress test before they start. It's not a functional stress test. It's usually a 2 or 3 minute stress test. And we have to wait for the patient to see the doctor, get the stress test scheduled and completed. And then, so sometimes it can be, over 30 days, maybe even 40 days, a month, month and a half after discharge before they're able to start cardiac rehab. And that's just way too long.
Thank you, Cindy. Jim?
Yes, one of the things that we do for registration is that we do a group orientation once per week. So we'll have a group of about 10 or 15 patients who are starting for that week. They'll meet as a cohort, and we'll collect identification information and insurance information at that time. And then we're able to pre-register them so that when the patient arrives, the registration staff, they will register them on a one-time basis, ensuring that all the paperwork is complete, making sure that everything that we need for that patient is in the system. After that, the cardiac rehab staff is also responsible for checking in our patients and billing our patients. Now, I do have a medical assistant who's that's one of their main responsibilities, but it is shared from within the clinical staff as well. One of the nice things about our system is that our registration system does talk to our cardiac rehab telemetry system, so that information is propagated within the system when a patient starts. So we don't have to worry about any issues related to account numbers being mistyped or medical record numbers. Those are all transferred in nicely. As far as getting patients into the program, I think everybody wants to see those patients in within about 2 weeks, but the reality is it probably is closer to 3 to 4. In this electronic age, it is nice that we can see those cardiac rehab orders go right into a cardiac rehab queue so that we can pull them. We don't have to rely on them being faxed, but we do still take a lot of faxed orders as well, especially from the university-based system.
Yeah. I like the idea of doing a group orientation. Have you found that has expedited the process of getting into cardiac rehab?
Yes, I think it does, because you're taking an hour session and speaking with 10 to 15 patients versus doing that on an individual basis. So all the details of your cardiac rehab, explaining what it is, what days of the week, what they should be wearing, that's all done as a group instead of having to do that at the initial evaluation.
Gotcha. And then do you ever have a one-on-one follow-up with some of those patients in the group session, or is that kind of reserved for once they start and you can talk to them while they're exercising?
We will have each patient after that, they will get an evaluation where we'll go through their individualized medical history, we'll go through their goals, we'll go through ITP planning, and then they do that 6-minute walk on that evaluation. So each
Great.
person does have, in addition to the group orientation, they do have more of an assessment as well.
Right. The group sessions just serve as a great introduction into what they're getting themselves into, so to say.
Exactly.
Great. All right. Thank you, Cindy and Jim. The next question and the last question will be for Jim and Betsy. Are you using an ITP format from your telemetry software, or did you create your own in the EMR system? If you are using what your telemetry software provided you, did you modify any of its elements? And if so, what did you change or add?
This is Betsy. We created our own ITP. We tried using the ITP. We have LSI, and we intended on using the ITP and LSI, but what we found is we only have one monitoring station, and there's usually 3 or 4 staff members working at a time. And as we all know, we tend to do our reviews during class. So that initial orientation we do one-on-one, where we start to fill out the ITP. So we do ours hard copy on paper because we find it's a working document. We're constantly adding and changing things to it. And if we had to wait to sit down at that workstation to make a adjustment to the ITP, it just simply wouldn't be efficient. And then during class, we could have up to 15 patients on the monitors. We could have 15 patients exercising. 3 of them might be due for their monthly review, where we'll go over their goals and do their reassessment on their ITP. So that's why we like to have a hard copy where we can just walk over. I'll stand next to them on the treadmill and go through their goals for hypertension, their goals for diabetes, whatever their risk factors might be, and do the reevaluation right there live during class. And again, if we had to do that on the computer, it just wouldn't be efficient for us.
This is Jim. We do use the ITP that comes with SCHR, but I'll say that it doesn't really look much like the one that SCHR provided. I did get a chance to speak with some of the technical help there, and they did come out, and I was able to really customize an ITP that would all of the components that we would want to see in an ITP, everything from assessment, reassessment, and follow-up that you would typically see for a patient for billing purposes, for Medicare purposes, for treating that patient. The program we use is fully customizable. The one disadvantage to this is that it does require a physical signature by the doctors on it for the signature every 30 days, where I can see that if you're using some of the EMR systems, there is some capabilities for remote signing. But the system I use is fully customizable. They can pretty much add in anything that we want, and it's worked well for us.
Great. All right. Thank you so much, Jim and Betsy. So this concludes our panel roundtable Q&A session. The ISCHR would like to thank the entire panelist group for joining us today and taking time out of their busy schedules. We also would like to thank the ISCHR members who submitted questions for this panel roundtable Q&A. This session was recorded and will be available to ISCHR members on the ISCHR website. Please note that the ISCHR Education and Northern Region committees are working together in planning a speaker event in the fall. Please keep a lookout for other education events in the future. If you are interested in becoming involved in our ISCHR committees, please see ISCHR website. We would appreciate any feedback that you would be able to provide. If you have any feedback, please send those to Jeff Laporte via email below. Thank you and have a great holiday weekend.